Right, folks, I'm going to begin. For those of you who were at the aborted attempt to do this a few weeks ago, apologies. And I'm just hopeful that the tech is going to work well. I was slightly surprised the chat was disabled, because I was thinking that might be a way for people to creatively interrupt me. Jill has just explained that because it's structured as a webinar, not as a meeting, that is disabled, I guess. That's implicit. But I think the Q&A does work, or at least I'm able to see your questions. So I'm happy to be interrupted, probably best because of the number of people. We're at 17 now, to do that via the Q&A rather than raising a hand. There will be time for Q&A at the end anyway, because I'm not planning to go on too long. And I suggest we just get started. So the title here probably reaches the Trades Description Act, because it implies that I'm going to focus on what to do once things go wrong. I'm going to do a little bit of that, but most of what I'm going to do is actually talk about, and as soon as I get the slide to move, talk about prevention and learning from mistakes when they do happen. I think I said in the little script or description of this masterclass, and by the way, I really hate the term masterclass, but never mind. That is what it's titled. That you're going to have to make your own mistakes, and that actually we do learn from our mistakes. And the purpose of this session is not to help you make fewer mistakes. Maybe actually it would be nice to make fewer mistakes, but particularly to learn from them. And what I've done is I've gone through my own work over the last more decades than I care to remember. And it wasn't very difficult to remember the mistakes. And that's what I've tried to collect together into the presentation, to do some generic stuff, but also drill down to some of the mistakes to see how indeed they could be prevented or mitigated. So that's what I'm going to try and do. What I'm going to use as a structure, and this may be familiar to you, this cycle, the cycle of research studies, which has a circularity. I like to think it's not circular, it's more spiral-like, but because this is in 2 dimensions, you can only see it as a circle. To separate out the various stages of the research process, because as I was thinking about this, I realized I've made a mistake in every step of the research process, more than one actually. And I'm going to select the ones that I think are most instructive. I'm going to start with the development of the research question. That is the place where I've always started, and I hope, or I assume you guys are starting for the studies that you're designing or indeed doing. For me, the biggest mistake, I may have made it a couple of times, but mostly actually I've avoided it, I have to say, is developing research question that you don't really care about. That can happen for all kinds of political reasons, personal reasons. It may, for instance, be that you're working in a department where the head of department thinks this is a really important question and has managed to get funding for you to be involved or offering involvement. That's not a good reason, although one has to cope with the politics of departments, obviously. But because research is difficult, it's really important that the original impulse for it has to be one that is important for you and that it matters to you. This is quite subjective, obviously, because a topic that matters to one person may not matter to the next primary care researcher. But figuring out for yourself what really interests you, I think, is mission critical. Where do those questions come from? So my personal experience, and this is not a mistake that I've made, this is the thing I got right, was that it came from my experience as a GP. Now, I know not all of you are clinical researchers, so you may need to find the inspiration from other sources. But for me, so on one side here is Lower Clapton Health Centre in Hackney in East London. The top right is Helios Medical Centre, now closed down in Bristol. And I finally landed in Montpellier Health Centre, also in Bristol. Very similar in some ways to Lower Clapton, so I kind of come full circle. I think all my questions, all my studies, in one way or the other, have been based around my experience and my frustrations sometimes around the lack of evidence as a clinician. And that's been quite an important sustaining feeling or sustaining energy around it. I'm not saying it's got to come from your clinical experience if you're a clinician. I'm just saying that actually it helps. And if you have other sources of inspiration, that's fine too. But it's got to matter to you. It's, I would say, necessary, but not sufficient condition. And the mistake can be pursuing research where that doesn't, that's not the case. This was the start of my own research. This was an MD, the kind of poor clinician's PhD, if you like, then. Wouldn't get away with it now. It was a study about the access to healthcare for traveller gypsies, as well as some data collection around their health status and cardiovascular risk and access to reproductive and sexual health services. It was based around the fact that we had traveller gypsy patients who I would sometimes see for a few consultations, then they would disappear for a year until they came back to Hackney. I was aware that we weren't providing a very good service in terms of accessibility or follow-up. And the point of this masterclass is not to give you the details of the research I've done, but to say that, but this is an example of where I was inspired with real questions. I was also influenced by the fact that there were still pubs in Hackney that said no travellers, or travellers not welcome. And there's something about the symbol of not having access even to a pub and difficult access to primary care that drove that research through all the challenges of doing primary research and delivering a thesis, a dissertation, which I think many, if not all of you, are involved in that process of writing a thesis. So it helps, and the mistake is for it not to be inspired by something which you care about. The next mistake or problem is that the actual research question, which may be of great interest to you, doesn't in fact need answering. Now, interesting enough, this mistake is one that is much more difficult to make now, because when I started my research, systematic reviews were still relatively in their infancy, whereas now they're very much, part of our research landscape. It is possible, thankfully, through searching and through the web, and through Prospero and PubMed and all the wonderful ways we have of accessing not only what's out there in terms of published research in PubMed, but actually what has been posted as work that's being conducted, reviews are being conducted. You will know fairly quickly whether the research question that really bugs you has already been answered. And if it has, that's great. And you build on that. So I don't think this is a mistake that you're going to make. At least you shouldn't make it. because at least from a scientific point of view, you should know if that question has been answered good enough. I mean, there's a whole issue about whether one should replicate studies, which I'm not going to get into, but you'll have some idea of whether the question has been answered. That still isn't quite enough. And the key question here is who wants to know? And the mistake is not asking the question, who wants to know? The driver for research can't just be an unanswered question, I don't believe. I mean, you could argue on scientific grounds, possibly in some fields, but I think in our field, in the field of primary care research, particularly kind of health services research, we need to figure out who wants to know the answer. And stakeholders, now the concept of stakeholders is much broader and has grown more broadly over the last couple of decades. Figuring out whether stakeholders really care about it, and stakeholders, particularly if you're trying to develop an intervention, are going to be commissioners. Figuring out if patients, people with lived experience of the condition, care about this and prioritize it is equally important. The involvement of people with lived experience through patient and public involvement has grown substantially. I mean, it was actually off radar 30 odd years ago, and now it's very important. So who wants to know? And that includes whether patients and their families want to know the answer to a question. I'm not saying that it has to be, I'm not trying to weigh these up, because the relative weights will vary, but you certainly have to address that question. And a mistake which actually I still see all the time in supervising, particularly PhD students, but even sometimes postdocs, is trying to answer too many questions. I mean, it seems to me the main role of a PhD supervisor at a relatively early stage of the supervision is to say, cut out the third study or fourth study that you want to do in a thesis. Now, I think this is also true in grant applications when you're in the postdoctoral phase of your research life, trying to really focus. And there are many questions that you want to answer. The questions that you can answer within a PhD or within a study you're applying for funding for will be less than that, will be fewer than that. And how to prioritize that within your own kind of batting order is a key skill. And the mistake gets made again and again of too many questions. And I guess that the final mistake or pitfall is that I don't think one can spend too much time, although if you've got a grant deadline, you're going to have to cut to the chase at some point. But I don't think one can spend too much time in theory in refining your research question, because the clearer it is, the clearer you can articulate it in relation to the methods you might be able to use to answer it, the stronger an application will be, and the less problems you will have down the line as you're trying to conduct research if you do get the funding. And I say delayed abandonment because one sometimes has to abandon a research question because you can't answer it, and you may be abandoning it before you even do a pilot. But don't delay abandonment if you realize it's just not going to fly. So I'm saying two things at once: spend time refining, but be ready to abandon, to cut your losses. What I'm going to be doing in part of this talk is give you some specific examples, concrete examples. I'm not going to do that on some of the issues because they're quite delicate, and I want to respect confidentiality as well. Because talking about mistakes and when things go wrong can be sensitive. It's easy enough for me to talk about the stuff I've got wrong because I'm disclosing that to you, but I don't want to do it by way of criticism of any colleagues. So some of this, I won't actually give you a concrete example. Mostly, particularly a bit later on, I will. you got to work with people that you get on with. I mean, this is so obvious. I mean, it is like, you know, kind of preaching to the choir a bit, but it's obvious, and yet you may or may not be surprised how often this does go wrong. Temperamental incompatibility doesn't mean that you have to have the same temperament. In fact, that would be quite wrong. And different styles. I mean, I'm a good starter. I'm a rubbish completer. I work really well with completers. So that's not the kind of incompatibility I'm talking about. That would be complementarity. Incompatibility is when you really don't get on with someone, either you don't quite trust them, or they're a bit of a bully, or I shouldn't say a bit of a bully, or they're a bully. And it doesn't get better. In other words, I mean, I'm an optimist, so I always think things are going to get better. But my bad experience, and I haven't thankfully had that many, and I think within primary care, we on the whole have quite a good culture, supportive culture, but the examples I have in my head, which I'm not going to talk about in any detail, is where right at the beginning, I had a feeling this wasn't going to work with a senior colleague. And we were joint applicants on a grant application. And my initial intuition was right. I didn't listen to it, because I thought, we'll sort it out. We'll sort it out. We didn't really sort it out. And even though we carried on the study and we wrote together, it was an unhappy experience. And I think that if you can avoid that, if you use your intuition, and if you needs a bit of self-knowledge about, you know, why is it that I'm reacting to this person? Is it something that can be sorted? But I would listen to that voice. And certainly a mistake I've made in a couple of times is not listening. I have not made that mistake in the last 20 years because it was unpleasant. The second mistake with colleagues, I think, and this is probably more when you're leading a study, you know, I mean, you guys will be leading studies, is when there's a problem in team dynamics. Again, it usually doesn't get spontaneously better. So it's better trying to address it early on, even though it's uncomfortable. And you know, and my lesson, my mistake was for a trial. I did not address the problem. I did not bring the team members together to discuss what's going on, and it just got worse. So by the time I did sort of wake up, think, shit, this really is a problem, it was already much more complex. So, you know, it's a bit, I guess, a bit like being in a relationship. You know, if you've got a problem, it's unlikely to spontaneously get better. If there's a problem in the family, try to address it. So these are difficult lessons. These were difficult mistakes, which I think probably are avoidable. And in terms of training researchers, probably we should do as much training around this kind of issue as we do around, you know, how to do a good systematic review, or how to generate a Kaplan-Meier curve, or, you know, how to do meta-analysis. You know, this is what makes research more or less successful, as well as making you more or less happy. Next mistake, and these are real mistakes. So, you know, you got to get the authorship issue right from the start. It's much better to specify who is included as an author, and even, I'm afraid to say, authorship order. And my big mistake here, which, you know, I did learn the hard way, was just avoiding that until we were actually writing the bloody paper. It doesn't work that way. You should, and you know, the ICJME guidance is good. It doesn't talk about order, but it talks about who's included as an author. But authorship order does matter to people at different stages of their career. I mean, at this stage in my career, it matters not one iota, one jot. But if you're mid-career or early career, it really does matter. And other thing is, globally, it varies. So in some countries, being last author doesn't matter at all. Being corresponding author or first author is the key thing. You've got to figure, if you're doing any kind of global collaboration, you need to have those conversations with colleagues around that, it's really worth specifying from the get-go. Also, and this is a concrete example, if someone goes on maternity leave, it doesn't mean they don't want to be an author. You know, and they may not be answering emails, and you need to figure something out before they go on maternity leave. How are you going to communicate around that? So yeah, it's tedious. The whole authorship thing is, you know, with ref and with promotions it's a pain. It's, you know, and it's got nothing to do with the science of what we do, or even real attribution of credit, but you have to pay attention to it. I'm not a very good manager, I have to say. I think I've learned some stuff, but not as much as I probably should have, given how long I've been in the business. You know, being really clear about division of labor and what your expectations are of, well, of yourself, of your peers, but also if you're running a study of the people who you're line managing. The mistakes I've made is fudging it or keeping it ambiguous, not paying enough attention to that, not crystallizing it out in a either in a document or some kind of SOP, you know, standard operating procedure, something that says what different people are responsible for and the expectations of what they can deliver. You can't, you know, this again, this nothing to do with the science, but it's a lot to do with the success or failure of research. This is the methodological support issue, particularly if you're a clinical researcher and not a methodologist. I'm not. And so my mistake here was actually back to my original research with Traveller Gypsies and my thesis, my MD thesis dissertation, not recognizing the value of methodological support. I did get some statistical support, which was probably just about enough given the primitive statistical analysis that I did. Didn't really get the support around the qualitative research, because I did a series of interviews with traveller families, as you can see in that picture of a younger version of myself. In the end, I was really stuck with my analysis of really rich data. And I was, unfortunately, I was rescued by one of the doyens of qualitative research. Well, I don't know if he'd call himself that. David Armstrong, who's a medical sociologist, who actually went into his office. And I spent 5 hours with him, showing him my data and trying to put together some analysis plan. Why I didn't do that, I think if I'd had, I'm not going to name names here, I think if I'd had a good supervisor, probably they would have got me to do that, or obviously would have got me to do that early on. My supervisor was pretty hands-off, so I had the hubris to think, well, you know, I can just do this, and I couldn't or didn't, and in the end did need some rescuing at the end. It was very salutary, and getting the right methodological support at the right time is crucial, not just in a PhD, but it's actually crucial throughout any research that you're going to do. We're blessed in Bristol, as I guess you probably, in most of the national school departments, blessed with wonderful methodologists across all the methods you could ever use. Yeah, use them, get them involved as collaborators. And don't stint on that, and particularly in your grant, if you're doing a grant application, don't stint on that. The other big mistake I've made is not have sufficient project management. The bigger your study gets, the more you're going to need this, and admin support. Undercosted it, underspecified it in my early grant applications. Really rued the day, regretted deeply. I'm going to see that there's another Q&A, so if someone wants to interrupt me, it's just, will a recording be shared? I think the answer is yes, that we're going to give the recording to SPCR and they're going to share it. So if you want to go off and have some lunch, you know, please do. Yeah, it's the same thing with methodologists. It's almost like you can't have too much project management, and it makes such a difference. And if you're running, particularly if you're running a trial, if you're running a program, it makes all the difference. And so my mistake has been not building it in, even in a medium-sized study. My great benefit now is recognizing that I need it, and working with some excellent project and program managers. It's absolutely mission critical. Now, you can't have that in a PhD. So I think, the thing about a PhD is to learn about a project management while you're doing the PhD by talking to experienced project managers who may not be best represented in your supervisory team. You may need to reach out to them in the department and talk with them about aspects of actually managing research. Let's move on. Move on to the next stage, which is designing the study. The first one I'm not even going to linger on, because of course your study design has to be fit for purpose. How do you decide that? Well, if you're a PhD student, your supervisors have a real responsibility in helping you do that. If you're a postdoc, by then you should have enough knowledge about the types of questions that can be answered with different methods. It is worth really thinking carefully about that, obviously, and particularly talking about it with the methodologists. I don't think I've made that mistake. I put it on there because I've seen that mistake being made, but I don't think I've actually made it. I think I've always felt stupid enough, or stupid is perhaps the wrong word. I've always felt not expert enough methodologically to then turn to methodologists to really talk through what the exact design should look like. And then, of course, as I became more experienced, I kind of knew what they were going to say, and I could own it myself. The next mistake I have made, and I go back, it's for those of you who are developing or evaluating interventions, it's crucial to have some kind of process evaluation. Now, this was not seen as crucial when I started off as a researcher. I think now, particularly with NIHR, process evaluations are valued and are funded. The example I want to give of the mistake is that we did a trial of, well, as it says, postal prompts to patients and their GPs. These were post-MI patients. And we wanted to see if using postal prompts would actually get the GPs to engage more with secondary prevention. And that if the patient knew that was something that was expected of the GP, whether they would also prompt that, even if the GP didn't invite them back. And I think we've got a lot better within general practice in reviewing our post-MI patients and making sure they're on secondary prevention. That wasn't the case in the mid-90s. Anyway, it was a trial that didn't actually work. In other words, I think we had better recording of cholesterol, but we didn't see any change in the prescribing of statins. And there were a couple of other, well, two primary outcomes, and we achieved neither of them. There's a bit of evidence that that there had been more consultations which dealt with secondary prevention, but no actual improvement in secondary prevention. I mean, I don't like the term negative. It's important to have a trial that shows that something doesn't work. But what we missed completely was the opportunity to do a process evaluation to figure out why it didn't work. Was this because the GPs actually didn't think it was important? Was it something structural? Was it, at what level was the problem happening? If you don't do a process evaluation, you don't really learn from a trial that shows an intervention is not effective or cost effective. So that was a mistake, and I learned from that. always do a process evaluation, because when I look at the trials I've done, and I've done a number, a number in 2 digits, I think, I would say about half of them showed an effectiveness and cost effectiveness or cost effectiveness in intervention, half didn't. But now we know the ones that didn't, we know why, or at least we have some idea why, so that one can either jettison the intervention completely or improve it. Another mistake is to skip over a pilot. If you're evaluating an intervention, it doesn't have to be a trial, any kind of evaluation, always pilot it. In fact, probably always pilot anything that you do. And, you know, I have a few examples where, in a way, the post-trial may have been an example of that. If we piloted it properly, we probably would have changed the intervention so that it was more likely to be effective. I'm not saying it would have been, but it's possible. So the mistake we made with post was no pilot and no process evaluation. What's wrong with that picture? But so, yeah, it's an avoidable mistake. Getting funding for pilots is a pain sometimes. You know, NIHR keeps changing its mind around that. And now HTA does embedded pilots, which is probably better. But anyway, there's a whole other conversation there, which we don't have time to do today, but that, you know, there's a strategy for how you make sure pilots or feasibility studies are funded. Just think about study design again. I am a trialist, but actually I've overcome my obsession with trials, still the least biased way, blah, 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 because there are other methods that one can use to look at interventions that are quasi-experimental, which I think now, again, NIHR and even MRC are becoming a bit more relaxed about that. Again, talk about this with your methodological colleagues. My example would be an interrupted time series. So we've used that to look at the effects of an intervention around domestic violence. It's the IRIS intervention, when we were interested in seeing if it scaled up in implementation terms. And we didn't do it as a trial. We did it in areas that were introducing IRIS. And we got a signal. We got a signal. I mean, you could argue, well, how do you estimate the effect size? And talk about it with your statisticians. But, you know, there was a signal that the intervention really made a difference by repeated measures taken over time. And in commissioning terms, just as compelling as a trial. Probably more so because it's happening in real life. It's happening outside of the rarefied context of a trial setting. So it's while we're on obsessions, even though I'm obviously a great fan of systematic reviews, I also think they're very burdensome, and those of you who are doing them or have done them will understand that. Not the only way to review what evidence is out there. And again, there's now a greater permissiveness around this. I mean, for me, the main problem is the resource that goes into a systematic review. And my example of this, I don't know if this is a mistake, but it's certainly a problem, would be this systematic review, which was around screening. By the way, it showed that screening for domestic violence abuse is not effective. Now, the problem with this, I'm putting a circle around the problem. I don't know if you can see that small circle around the date. It's now 10 years since we did that review. I'm trying not to swear with my adjectives, by the way, because I'm aware this is being recorded. 10 years. And the only reason is because we haven't had the protected time and resource to really update it, because there have been new studies. And I know this isn't the completely popular view. One of the problems for me is systematic reviews, because of the resource, is that the best becomes the enemy of the good, particularly if you're doing a Cochrane review, which is definitely sometimes the best being enemy of the good, because they are the best, but they are hard work. So, and in terms of PhDs, you know, I do encourage my students to think whether they actually need to do a systematic review, have a second reviewer, go through all those steps, or whether there's other ways of reviewing the literature. You know, more that are more biased, and there's always a risk that you're going to miss important studies if you don't at least do the search systematically. I think what happens after that, one can debate more. Anyway, but the systematic review obsession is something, I wouldn't say it's a mistake, but it's something we need to be mindful of. Right, moving on through the research cycle. How are we doing for time? We're just about doing okay. So you've had a good idea, it inspires you, you've avoided some of those pitfalls or those pitfalls that I've fallen into, and you're on the data collection, you're actually conducting this study and you're getting primary data, or are you? I think a mistake I've made is making assumptions about data access and availability. This is a mistake I'm making in real time now, because there's this cornucopia, this richness of routinely collected data out there now, you know, from the electronic medical record, from hospital records, from social care records. It's, you know, we're in an era now where there is a lot of individual level data, but a whole bureaucracy around to protect the confidentiality, or the de-identifiability, if you like, or the identifiability of the data. And we've created in our research culture a real complex machinery, if not a labyrinth, to getting those data sets and being able to link them. And it always seems to take much longer than we think, even with all the emphasis on big data and its potential value. So, you know, I guess the mistake I made is to always make optimistic assumptions about data access, even as I said, into 2024 and availability. This is a mistake I made not around big data and about some of these large data sets from statutory services, from health service. This is a study, a randomized controlled trial of, as it says, actually, what it says on the tin. We didn't do it in the NHS. We did it within a third sector organization, or within two third sector organizations. And I made some optimistic, I would say now in retrospect, lazy assumptions about the ways they recorded their data, their contact data, and even some, we didn't collect outcome data from them, but we wanted to collect contact data. And, you know, even to just, you know, do the consort diagram also about the number of potential participants and all that. We didn't check. It's unbelievable for me to be disclosing this. We didn't check to make sure that those data were collected systematically, or at least reliably. Until halfway through, we realized there was going to be a problem and there was going to be some missing data, and we then pulled our socks up with the organizations. But again, you can't spend enough time, I would say, making sure that the data you're relying on, particularly in a trial, that wasn't the case here, that it wasn't the primary outcome, but particularly if it's the primary outcome, that is being collected in an unbiased and reliable way. It's paying attention to that level of detail, which will stop you shedding many tears, you know, as you get into the analysis phase. So that was definitely a mistake. So the other thing is, you know, if it's administrative data, and particularly, and that's actually true if you're getting it from general practice as well, or from National Hospital, you know, from HES, you know, there's missing data, but you're kind of you're assuming that it's well, you're not putting the resource into collecting that data yourself. You're getting it off the systems, and you almost accept a level of missing data, which you then have to cope with in the analysis. If you have some control, like we did in the third sector organizations, of actually improving the administrative data, by all means do that, but you can't do that if you're using national data sets. So then you think, okay, well, the opposite. Well, if it is study specific, if we're administering the questionnaires and if we're collecting the data, at least we have that, we have control over that. Okay, we may have missing data if participants drop out or we can't follow them, but at least the data we have are complete. Don't assume that unless you've built in the system to make sure it's complete. And my example is actually current, almost lived example. Well, I guess it is a lived example. So we're running a randomized controlled trial of a perpetrator program, and we're administering the questionnaires for the primary and indeed all the other outcomes. And we do it, with a really good team. We have a really good team, and we have a good backup from the trial center. But we had missed the necessity of checking the questionnaires when they came in real time, not waiting till there were 20 or 30 and then going through them, to make sure that the primary outcome, that all the components of the primary outcome questionnaire were filled in. And when we did look at it, we realized that there were going to be some missing data because some of the participants had missed out items. Had they missed them out at random? Or is there something systematic going on? That's a good question. What to do when things go wrong. So this goes back to my original title for the masterclass. We have got permission to contact some of the more recent participants who missed out items and got them to give us how they thought they would have responded. Bit, questionable that, but it's better than a blank. So what's the lesson? So, but the lesson is don't assume anything. Maybe that's the kind of mantra overall. Don't assume anything, check. And certainly when you're getting in, and this is actually good practice anywhere. It's ridiculous that I'd missed, building this into the SOPs to always check your questionnaires when they come back, just in case there is something missing, and then you have the opportunity to go back to the participant in real time. I would say it's a a research 101 mistake, but yeah, don't assume anything. And then, and this is, I just thought this might be of interest to see the sort of trade-offs around administrative and study-specific data. And, just to walk through it, with administrative data, you get almost complete follow-up of participants. You don't necessarily get all the data about them, but at least you don't lose the participants because you never consented them to be in the study. It's an administrative data set. Relatively quick and cheap to obtain. I mean, it's, anyway, that you can debate some of that, but certainly compared to a bespoke questionnaire that you're sending to participants. You don't have to recruit, you can get ethics approval to use that. Sometimes we've done studies where we have recruited participants and used administrative data, but it's not necessary. You don't have to do it. The data are already coded or easily codable. And in an era of natural language processing, you can actually also code free text. And you can follow, particularly within NHS data, you can follow them up forever, because they're always there as a patient within the system. The downside is missing data because the people collecting the data, i.e. frontline clinicians, are only going to do it for their purposes, not necessarily for research purposes. I've already whinged about bureaucratic hurdles. And then probably the most crucial thing is not necessarily the outcomes of interest. For instance, we don't measure quality of life in general practice, an important outcome. Study specific, you can measure the outcomes in a validated way with validated tools that you're really interested in. But, participants may actually exclude themselves. Once they've been recruited, they may drop out, or they may be lost to follow up. And there's also the issue of response burden. The more pages there are on a questionnaire, the more likely you are to have missing data, or if you really haven't powered it properly, for the participant to lose the will to live. So this is also part of piloting. Questionnaires are always, it seems to me, too long. Okay, moving on. So you've got your lovely data set with all its warts and all. Here, there's this real distinction between doing everything yourself, which as a PhD student, you probably do, and there's some exceptions to that, and being a postdoc and beyond. So my mistake, I don't know if I've really made this that comprehensively, but I do know colleagues who have. My mistake was carrying on doing analysis not well when methodologists could do it well and more quickly. As I say, I didn't actually make that mistake because I didn't ever feel particularly competent, but I won't name any names, but some of my senior colleagues, not in Bristol, but well, actually in Bristol as well, really like doing their own analysis. But I think I'm not sure it's the best use of time if you're a clinician researcher. You may actually be very good at it, but it's probably better to divide the labor differently. I think the take-home message isn't don't do your own analysis. The take-home message is think what you're capable of doing well, who your colleagues are, what the resources are, and act accordingly. It's to think about that division of labor and not to assume anything. Yeah, so I've already kind of talked about this. Getting methodologists involved later on, once you've got your data, it's the statistician thing. They look at it, the data set, and it was like the joke about, that you ask the New Yorker, how do I get to Carnegie Hall? And New Yorker looks at you and says, I wouldn't start from here. That's like the statistician saying, the structure of these data are not really going to be analyzable in a very good way. So yeah, getting that methodologist, I've already said that a million times, from as early as you can afford, or as early as you can call in favors on. This is important about working out your disagreements at the protocol stage. And I guess the mistake I've made in the past is to leave it a little bit too late. And one of the healthy things about writing a protocol paper and then posting a SAP, a statistical analysis plan, or an analysis plan more generally, including the qualitative, is that you can have those discussions and disagreements and resolve them, rather than trying to resolve them when you've actually got the data set and your grant runs out in 3 months. So yes, get it, do the interesting, this is one of the most fascinating parts of research, debate around analysis before you have the data set. Okay, moving on to conclusions and interpretation. The main hazard here, which you've probably heard about in various forms of training, is to over-egg it, to make too much of your findings, because that's what we do. Because people tend to exaggerate, and the literature is full of examples of over-egging, which is a technical term. I've done it. So in the main IRIS trial, we looked at an education, a training and support intervention for general practices around domestic violence. We looked, the two primary outcomes were referrals and identification of patients with exposure to domestic violence. And we found a substantial difference for both. But and a large relative improvement, 16-fold or something, 16-fold difference. But the actual absolute improvement difference was substantially less. So this is exactly the same as a drug trial. If you report your relative risk, but not your absolute risk reduction, and don't do numbers needed to treat, then it exaggerates. And I think we're really prone to this. And so the example here is, when you look at the proportion of eligible women in the practice who were identified, we are talking about less than 1% in, so let me do that. Well, it maybe between 1 and 2%, I guess you could say, less than 2%. When you think the prevalence, forget prevalence, look at the incidence of domestic violence in the last year, which in various populations, particularly in general practice populations, maybe as high as 15 to 20%. The difference is important, but it's a relatively, it's a relative risk reduction or relative improvement in identification and referral. And there's a long way to go before the practice identifies almost you could say clinically important proportion of patients who are exposed to abuse. When I say we over-egged this, I mean, we didn't make any really big claims in the trial paper, but a friend and colleague who wrote the editorial in the Lancet around the paper pointed this out very, very strongly, that, it's a big relative improvement, but not a very big absolute improvement. It's just an example. Again, I wouldn't say it was a mistake. I think some of the language that she used in the editorial, we probably should have used in the paper itself to just keep it modest. Keep it modest, I think, is the take-home message here. Write well, this is obvious, but you'd be amazed, or maybe you wouldn't because you've read lots of scientific papers, how poor sometimes the quality of writing is. I like to think I'm a good writer. It's one of my strengths, I guess, but that's not everybody thinks that's the case. So this is one of the funniest things that has happened to me. Okay, it was 24 years ago, but I still remember it. Michael O'Donnell, who's an absolutely wonderful medical journalist, wrote an article in the Lancet about that he called evidence-based illiteracy. And he used some examples of studies that it reported. And it wasn't even a study. It was an article I wrote in the BMJ with a couple of colleagues around guidelines, which used to be an obsession of mine. And anyway, faced with that sort of prose, you have a beguiling choice: pause and do the writer's work for them by trying to work out what they were trying to say, or throw the journal aside and set about something less demanding, like quarrying granite. I think he even said like quarrying granite with your bare hands. Maybe you've left out the bare hands bit. And it's hilarious, but it also made me feel really, is my writing really that horribly bad? I don't think it is, but the mistake is not to, when you're drafting, and this is obviously easier when you're working in a team with colleagues, is to make sure it goes through several people to get the language right. But yeah, I will forever remember that critique about quarrying granite with bare hands. Okay, you've written well, you've got a result which you'd like the world to know about. This is less of a mistake now than it used to be. I've made it a few times, and I'm going to give you one example. But the good thing is that NIHR, and even to some extent MRC, will allow you to price in some knowledge exchange or mobilization and dissemination costs. Always put that in. I mean, partly because now they demand it, just like they demand a statement around what you can do about PPI, but no point stinting on this. And one of the difficulties we have is, of course, these limits, like research for patient benefit. We do have limits about what we can apply for, but keeping money in there for dissemination is absolutely crucial, and getting advice on how to do that well. Here's an example where we didn't do it. This is the mistake number 63 or something that I'm talking about. This was a trial of an intervention to improve the management of patients with asthma who'd had an exacerbation, and this was in East London. We were particularly looking at the Bangladeshi community, and as an outcome, we had emergency attendance. The proportion of patients who didn't have to attend as an emergency in, I think it was the year after the index event. And we found, again, these are, you know, relative risk improvement, but it was a clinically important difference for that intervention in preventing another event, if you like, an unplanned asthma consultation or indeed admission. And it was a very pleasing result. I mean, we published it in the BMJ, blah, blah, blah. But we didn't do anything about trying to integrate this. And it wasn't, we didn't do a cost-effective analysis, but actually it was a pretty cheap intervention. It could easily be incorporated. We did nothing about integrating even into practice in East London, never mind nationally. And that's a mistake. And you know, won't make that mistake ever again, because, you know, if it had legs and if it was implementable and scale upable, I know that's not a word, could have really made a difference. So, you know, who cares? I mean, we care, it's in the BMJ, we care that we get a grant and all that stuff, but actually what you care about is making that difference. And here's an example of where we did it was a robust, not easy trial with an important result, but that was it. So yeah, that's to be avoided. The next one is relates back to that initial thing when you're designing a study, is who wants to know. So the who wants to know here, I think in the NHS at the moment, is about commissioners in the ICB, getting them on board early on to know that you're to consult them about the study, keeping them on board through maybe some communication that's not burdensome through the study, and then being ready to work with them, either on a local level, if you want to do some local scaling up first to see if it can be scaled up, or indeed nationally. It's that extra work which, again, NIHR, to some extent MRC can actually fund. The mistake is not linking it to who wants to know. And I'm going to give you an example of that mistake. So this was, I mentioned this before, this was the PATH trial, which was a trial that showed a real benefit, clinically important benefit on mental health for women who got this additional psychological intervention, as well as their normal domestic violence advocacy. And we didn't build in enough work around knowledge mobilization or knowledge exchange. We didn't, even though we made up for it a bit by getting some support from our own university in their commercialization department, but we didn't really achieve what we did with the IRIS intervention of getting it in a commissionable form. I'm not saying we would if we'd put more resource in necessarily, because there's all kinds of reasons that this is a more difficult ask of commissioners than the basic, you know, domestic violence intervention. But the mistake was not to think enough about and to get resources within the trial for thinking about commissioning, developing a commissioning pack, doing some stakeholder engagement. So again, it actually was a lovely trial in the end, you know, despite the missing data, and with a clear result, unambiguous result, and yet, you know, at the moment, this has not been commissioned either locally or nationally, although we're doing some work to try to get it done, so to speak. And then, you know, the third thing is, mistake is not taking advantage of comms expertise. We're blessed within our center with a really good comms manager who's very astute and who we work with early on before trial or other evaluation research is published, in order to get ready for it having an impact. And I think that expertise it's a bit like a project manager or program manager, or indeed a statistician. These are people who really know what they're doing, and you can learn from and take advantage of their expertise. This is an example of where we got it right. So with IRIS, there's now a social enterprise that we use to disseminate the findings of that trial, which is now a national program 10 years down the line. And that, it's an example of getting it right. So it's not a mistake. All the mistakes are littered around it, as far as I can tell, of research that we haven't got properly into the world. So this is my summing up. Kind of obvious. You probably could have written this yourself. It's probably not even quite true. There are probably some mistakes from which you can't learn anything, but mostly you can learn stuff, and that's important. By the way, for those of you writing your PhD, your dissertations, always writing about the stuff that didn't work and why is, examiners do really like that. So it's also good reflective practice. So I just want to go right back to the failure to do this session a few weeks ago, when I couldn't figure out how to get Zoom to work for me. And therefore, kind of belatedly, given we've been through COVID when we were all on Zoom all the time, I learned a really uncomfortable lesson, which is always test the meeting first. I'm never going to try to do a webinar or any other session. I think I've just been very lucky in not having fallen foul of the gremlin. So yeah, so this is a worked example of a mistake and a subsequent learning. And I'm really glad that I've managed to get through this session without Zoom collapsing, or indeed my computer just crashing, which it does sometimes, but thankfully it hasn't in the last hour. So thanks for your attention. I've gone slightly over an hour. We did book it for an hour and a half to allow Q&A. I mean, you may have more important things to do, but I'm really happy. I'm going to take the slides away and open for Q&A. Now, we're still 18 people, so it's a good number. Probably still better to use if you do want to ask a question or challenge something I've said, preferably challenge and say what a load of rubbish that statement was. Then I think it's probably best to use the Q&A rather than use hands. And you may not have any questions. You may think, oh, okay, that was that. But I am here and available and remain available until it's clear that we have either no questions or run out of questions. A really interesting question. I'll read it. It's how to balance insufficient refinement on one hand and overthinking for project proposals at an early stage. I think that's spot on, because obviously it is a balance. And I think, and I'm going to almost give a generic answer because it probably relates to the other things I've been saying about how to get the balance right, or whether a balance needs to be struck. And to me, just looking at my own, lived experience of being a researcher, it's about colleagues and it's about pitching to colleagues. So again, it depends where you are in your trajectory, but certainly for ECRs, early career researchers, pitching not necessarily just to your, kind of to your supervisor or to your line manager, but pitching to someone else happens to have an interest either in the method or in the area, the condition. And that for me has been, the correct, it can correct both, because if you haven't refined enough, they will tell you quite quickly, actually, you need to, drill down more and to get that right. Or if you've been overthinking it and the thing looks too Byzantine and sort of not focused enough, they will say, hang on, forget about, X, Y, and Z, just concentrate on A and B. And so I actually think the blessing I've had I've had several blessings in my life, but a blessing I've had in my research life is wonderful colleagues who do not mind me coming to them with a question or an issue or a pitch. There are no stupid pitches. They're just like, there are never any stupid questions. It's, and you need to trust your colleagues to be able to listen, but also be able to say, do you know what, forget that, or have a look at this. So yeah, I think the answer is find colleagues who you trust to engage in a almost a Socratic dialogue, a kind of dialogue about your proposal as you're just stating it at an early stage. Okay, next question is, do you have any suggestions for journal selection for publication? Thank you very much. I'm a PhD student. I think, short answer is no, because there really isn't a generic answer around this. I think, by the way, submitting a paper while you're writing a PhD, manuscript while you're writing a PhD is a good idea. As a supervisor, I always say your main priority is your thesis, but God, that study's really come together and you finished it and you've already done the analysis and you've already written most of the chapter. Why not, top and tail it and submit it to a journal? I think that's a good idea, because if you're an examiner and you're opening a thesis, if you've actually got a physical version or looking at it on the screen, and there's an appendix that has 1 or 2 peer-reviewed papers in it, it either consciously or unconsciously influences your view of the thesis. Oh, this is already past peer review. Of course, in some countries, that's all a thesis is. It's 4 or 5 papers and an introduction and conclusion. A much better system. So anyway, I'll come back to try to answer the question properly, though. It depends on it depends on what work you want the paper to do. So there's issue about, open access. I think, we should really be encouraging you to always apply to an open access journal. So that depends on funding or your medical school or university having an agreement. The impact factor issue, I would say, forget about it. Forget about it now. Yes, when you're late ECR or mid-career, they're not supposed to pay attention to it in the ref, but we know they do in the ref panels. But I wouldn't worry about impact factor. And I think the other point, which relates to my dissemination issue, is that if you publish a paper in an open access journal, even one that doesn't have a high impact factor, but is relevant to your field and to the question, then of course the little bit of extra work about doing a policy briefing or some form of press release, that's what then gets it noticed. So that for me, the journal has become less important as we've had these other means of publicizing our research. Whereas in the old days, that it was, before social media, before university departments did press releases on small papers, it was probably more important. Anyway, I hope that's a useful answer to the question. The answer is it depends on those factors. Next question. There apologies if this is an obvious question. There are no obvious questions. Just checking with respect to process evaluation, do you mean incorporating qualitative review of the process or conducting a feasibility study first? I definitely mean the former, although it's not just qualitative. So this is a really good question. There's feasibility study, which may be a pilot. Not all feasibility studies, all pilots are feasibility studies, but not all feasibility studies are pilots. Classical paper by Sandra Eldridge on the issue of when is a pilot a pilot. So it's not, no, I definitely mean once you get the main study going, you need a process evaluation. Now, actually, the answer is slightly more. Oh, sorry, that's my dog. He wants to answer your question too. His answer is you could do a feasibility, you could do a process evaluation during a feasibility study as well. And if you have the resources, so I'm going to have to let him out of the room. When I was looking up things that can go wrong on Zoom, that's something that can go wrong. And he will shut up in a moment, I hope. So you could do a process evaluation within a feasibility study, and we have done those, because that may help you move the feasibility study to the main study more correctly and more appropriately. But the bottom line is, I would always, if you can afford it, do a process evaluation within the main study, particularly if it's an intervention study. And it's not just qualitative, you can also collect process data, quantitative data, particularly if you have a theory of change or a kind of logic model, and you can see some things that are worth measuring in order to get down the theory of change, get down from the theory of change into the distal outcomes that you want. But yes, they're two separate issues, really. And I guess I would say always, if you can afford to do a feasibility study, and always do a process evaluation within the main study. And that was Jill. Okay, so I hope that's a reasonable answer. Next question, is it feasible or realistic to work on a proposal that is irrelevant to your postdoc subject? And if so, how do we actually achieve this? I think that's a really cool question. And I must say that I'm not ambivalent about this at all. I think one of the privileges of our work as primary care researchers is that we can sometimes, well, we will get offers to be involved, or we have something to offer on subjects that are not directly related to our grant or indeed to what we looked at in our PhD. And I think it's, I'm not a great time manager. So as long as you've got the time to do it, I think it just makes the work more interesting. The other thing is that when you say irrelevant, I mean, often it may be relevant. It may not be relevant in terms of the topic, but it will be relevant in terms of the methodology. And so you may, for instance, I mean, an example would be colleagues who are particularly good systematic reviewers or become very expert in that, they may be involved as a second reviewer in someone else's systematic review, even though the topic isn't their topic. So as long as you can manage your time well, open brackets, better than me, close brackets, not difficult, then I think it is part of the joy of being also in a department where there are different research strands. And ultimately you may find that there's also some convergence, even though it may have seemed irrelevant early on. So yeah, I'm quite keen on that. Right. So Ludovine, unrealistic assumptions about data access. So the question is, have you identified a golden time to talk to data owners? Too early and project plans are not refined enough to get them interested and on board. Too late and major headache to alter course if they refuse access to their data. Again, this is such a cool question, and it's so based in reality. I mean, I guess, and you know, no magic wands here, but I think I've tried to have my cake and eat it. It depends a bit on who the data owners are, but my approach to this is to do a kind of heads up. Now, the heads up email, when it comes from a kind of senior person with some kind of reputation, probably is more effective. I hate to say it, but we live in a hierarchical society and within a hierarchical subculture, academic subculture. But a kind of heads up, we're doing this study, we're hoping to, you know, use, you know, these data sources, including the very valuable data set you have, but we're still now applying for funding, you know. I mean, you may want to ask them for a letter of support. That's already an extra step. Or you may just say, you know, do we have permission to say that we will be, you know, working with you about possible access? So that's, I think that's always worth doing. You don't lose anything by doing that. And getting a slightly senior person to do it may make it more noticeable. But then, of course, when you do get the funding, and then you go back to them and you begin working on the data sharing agreement and the different requirements. And by the way, this is even a problem for individual patient, individual participant meta-analysis, where you're trying to get data from trials, which one of my PhD students doing at the moment. And it's a nightmare. Because first of all, if the trial was 10 years ago, you know, the PI may have retired or died, and then they may not know where it's stored, and then their institution wants a particular kind of data sharing agreement, and that goes on and on. So I think, but I think a heads up is a good idea, particularly if the response is, we never share our data, just go away. And then at least you know you're not going to waste any time. So I think it's, yeah, I mean, unfortunately, and you're not going to like this answer really at all, you have to do a bit of both. You certainly have to do a bit of heads upping, and then you have to get ready to roll up your sleeves and have those what seem like sometimes interminable conversations, which are sometimes work very well at the level of the researcher, but do not work well as soon as that researcher talks to their research governance department. Anyway, this is something that needs to be sorted, because at the moment I think it's just it sort of has become, you know, too difficult. And I was talking to and I won't name names, but one of the senior statisticians here in Bristol Medical School, who 10 years ago wrote a wonderful paper about you know, individual participant data meta-analysis and how important it was, and and all the different kinds of things you could do with those data that you can't do when you're just looking at the effect sizes of individual trials. And we were having a bit of concern about trialists agreeing to share their data with us. And I emailed him to say, do you have any kind of advice or tips about you know, what kind of data sharing agreement everyone might be able to agree on? And he came back to me and said, no, I've actually given up on individual level participant meta-analysis. And he described a study he had that was fully funded, but he just, the individual trialists weren't willing, or not enough of them were willing to share their data. And when I read that email, something in me died a little bit, because I thought, God, you know, here's one of the champions of this, you know, a doyen of the field, who's actually stopped doing it because of the problems of data sharing. So I think there's work to do on getting this right. Right, how are we doing? We've got a little bit of time if there are more questions, but I'm very happy to give people 9 minutes to make a cup of tea or coffee. Right. Thank you for your attention. I mean, these things are weird. I mean, and webinars are weird, particularly if you can't see the faces of people. So I have no idea how this went down. Some of you have said some nice, generous things in the Q&A. Thank you for that. But yeah, I hope it's useful. I hope you make some mistakes that you learn from, but don't make other mistakes that are painful. And I'm sure you'll find your own mistakes. Do talk to colleagues about everything. And goodbye and good luck.